Morning. I'll call the Green Mountain Care Board's hearing of May 6, 2026 to order. We have two agenda items today. The first one is the ACO certification guidance and a potential vote that Marissa Melamed will present. And then we have the presentation on the Blue Cross Blue Shield proposed addition to its non-standard QHP offerings, which will be presented by Blue Cross and Staff Attorney Laura Beliveau. First, I'll take up some meeting minutes. We have meeting minutes from April 1st, 2026, which I move to approve.
Second.
All in favor of approval, say aye.
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 Aye. The meeting minutes are approved, and I also move to approve the minutes from April 29th.
Second.
All in favor, say aye.
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 Aye, and the minutes are approved. Ms. Melamed, I'll turn it to you for the certification guidance review.
Good morning, Chair Foster, members of the board. Just allow me a moment to the slides up. See that all right?
Yes.
Thank you. So good morning. Again, my name is Marissa Melamed. I'm a Healthcare Policy Project Director at the Green Mountain Care Board for the ACO Oversight Team. Coming back to you this week for a potential vote on the guidance that we presented last week on the 29th, if you're ready for that. So I'm just going to go through a quick agenda just to review what we presented last week. The Rule 5 policy statement, timeline, procedures, and summary. Any public comment, which we received none since last week's meeting, and the comment period was opened. If there are any board questions or discussions, and then any additional public comment. And if you wish to vote, we have motion language. So I like to just remind everyone what we're doing today, what the purpose of the amended Rule 5 and ACO oversight program is. The regulation of accountable care organizations seeks to strike a balance between enabling Vermont providers to participate in innovative alternative payment models and ensuring that ACOs operate transparently and in the best interests of Vermont patients and providers. So the rule and then the guidance to collect the information is meant to aid the board in that authority. The timeline. So we're actually a little ahead in voting on this at the beginning of May. The guidance does not need to be issued or posted until July 1, but we have it in advance just for scheduling purposes. So the guidance that you vote on today will be the final guidance and substance. However, between now and July 1, we still need to develop some instructions, some submission instructions, which may involve email instructions, or we may have a system to allow ACOs to submit through like Microsoft Forms and upload documents that way. So we do have in the motion language a delegation to staff to complete that. But the substance would be done today and posted, and ACOs would have access to that. But it won't be, the rule doesn't actually go into effect until July 1. So that's when it would be official. And then they have until October 1 to prepare the materials and submit their application. Because of the timeline of Medicare Shared Savings Program, some of those materials might not come in until November 1st. And then the board will review, board staff will review the materials and share with the board in November and December, at which point the certification would be reviewed and approved, or modified, or if conditions are necessary, or denied. And that needs to be completed prior to December 31st. We had to make one correction. The guidance did not have the filing fee amount posted, but the slides did, and there was an error there. So just I wanted to update that. It's a $10,000 initial filing fee, $2,000 annually thereafter. This is the first year, so this would be initial filing for all ACOs. And then again, here's just a summary slide of some of the information, or the bulk of the information that's in the certification application. There is a link to the guidance that was reviewed last week, and the board meeting materials, if anyone wishes to go back and review the presentation or the slides or the recording. We had a public comment period open for several weeks. We distributed the materials to stakeholders and interested parties, posted the draft guidance, and we received no public comments. So that completes the overview. There's potential motion language that we wrote here, but I'll turn it back to you, Chair Foster, in case there are any questions, discussion, and for public comment.
Thank you. I'll go ahead and make the motion and see if there's a second, and then we can have questions and comments after the motion. I move to approve the ACO certification guidance and application as presented by GMCB staff and posted to the GMCB's website on April 29, and to delegate to GMCB's ACO Healthcare Policy Project Director the authority to make minor modifications thereto, including the development of submissions and instructions.
I'll second.
I'll open it to questions for Ms. Melamed or any comments and deliberations on the motion. Great. Hearing none, I'll turn to the healthcare advocate for any comments they may have.
Thank you, Board Chair. So we appreciate the board staff's engagement with our questions and concerns, and we fully support the proposed rule modification. Thank you.
Great, thank you, Eric. And any public comment? All in favor of the motion, say aye.
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 Aye. The motion is unanimously approved. Marissa, thank you very much for your work on this.
Thank you.
Great. Next, we have a presentation relating to Blue Cross's additional plan that we spoke about last week, and we voted to hear and review the plan. So I'll turn to our staff attorney, Laura Beliveau.
Hi, good morning. I believe that Andrew Garland from Blue Cross Blue Shield will be making the presentation on behalf of the carrier this morning, and then staff comments will come after that.
Great, thank you. Nice to see you, Andrew.
Nice to see you too. Thank you, Laura, and thank you to the board for spending the time with us on this today. I will begin the presentation. I'll give a quick overview again of the product that we're asking you all to approve today, and talk about some key features, and then I'll turn it to one of my coworkers, Becky Law, who will go into more detail about the product. She's one of our product experts, and then we'll finish up by talking a bit about the marketing plan. And we've captured a number of questions that you asked us last time or sent over in between meetings, and we'll try to get those as we go, and we'll call them out so that everybody's aware that we're talking about the right things, and then plenty of time for other questions or thoughts as we go along. Laura, can we put the deck up, please? Or do you need me to do that?
I think you need to do that.
Okay, I didn't know I was allowed to do that. All right. Let's see here. There we go. Okay, can everyone see okay?
Yes.
All right. At this point, I can no longer see all of you, so please holler if you need my attention. So Vermont Basic, at its most fundamental, is a new set of non-standard product options, not replacing any products that were designed really solely to meet the goal of having more affordable options in the Blue Cross portfolio on the exchanges for both small group and individual. And to get to that more affordable price point, we looked at all the levers that are available, and truthfully, in this market, cost share and network emerged as really the only two levers that we could use to establish a fundamentally lower price point by moving the product design. We did that. We looked at the actuarial values and asked ourselves, where do we have the opportunity to move to a more affordable cost share plan and still stay in the same actuarial value? And then what can we do with the network to deliver something that is very useful to Vermonters, but also more affordable? And that led us to this plan design, which has plans in gold, silver, and bronze, all with deductibles that are a bit lower than are available on our other optional plans. It also has a comprehensive network designed around the state of Vermont and the contiguous counties in New Hampshire, New York, and Massachusetts, where many of our members receive care. And the product maintains the comprehensive coverage that is required by law and rule, and also expected of Vermonters and Vermont consumers. Now, I think we told you all when we met last time that on average, these plans are going to be 5 to 9% less expensive than their similar counterparts on the exchange, and the board asked for some details about where that 5 to 9% comes from. So first and biggest is the movement within the actuarial value range. So you know that a bronze plan should cover 60% of cost, but you also know that there's a window, a range of acceptable values from 58% of cost all the way up to 65%. Our bronze plans that were on the exchange last year were above that 60% mark and closer to that 65%. With Vermont Basic, we bring a plan, cost share design that moves us closer to that 58. So when we think about that 5 to 9%, on average, 5 to 9%, like a good chunk of it, depending on the plan, is coming from that cost share movement. Additionally, there's about a 3% savings on all of the plans that are directly attributable to using the Vermont-only network and eliminating the national network. So that's about 3% of the savings, or 3 points of the savings. And then finally, and Becky will talk more about this, we took the wellness drug rider off the Vermont Basic plans, and that reduces the price by a little bit less than a point. So altogether, that's how we get to the 5 to 9%. And of course, on Monday, the board will get exhaustive detail on all of that in the pricing.
So what's that noise? It's a bunch of somebody's mic not muted. Andrew, it doesn't look like you're rustling a bunch of papers.
I'm not hearing it.
God awful.
Oh boy. Okay. I'll try to be very still.
I don't think it's you. Is there a mic that's not muted somewhere?
I'm checking right now.
Okay. All right. Sorry, Andrew. It's just hard to hear some of the words they're getting covered.
I apologize.
Yeah, right there. That noise.
I'm sorry, I can't hear it. So please interrupt me and ask me to repeat anything if something gets lost. Apologize. So more about the design, and I think the key considerations. We did not want to disrupt anybody's offerings. So again, Vermont Basic, which is it's a very different plan design that has been available on the market because of the network feature. So we didn't think it was right to simply extend that into the marketplace and map existing members or existing plans to these products. These are entirely new optional plans. Nobody will be mapped to them. They're there if the market wants them. If they work for you and your family or your business, great. We're very happy for you to enroll in those plans. If not, that's okay too. One of the questions the board asked, I think, is what would the financial harm be if these plans are not approved? And there's no financial harm to Blue Cross Blue Shield of Vermont. We did not offer these plans as a membership play or a profitability play. These plans were offered simply to put more affordable options on the market right now. We know that consumers in these marketplaces are really struggling with price and of healthcare, price of health insurance, but also a lot of other things in their environment that are making them really have to examine their financial choices carefully. So we wanted to make more affordable options available. Vermont Basic is a plan for Vermonters who are not using out-of-state care and who are willing to take a lower premium to give up access to that out-of-state care. As I testified to all of you last time, I've been in Vermont since 2002. I've dealt with a lot of medical problems, unfortunately. I've never needed to use the national network. And if I were an individual purchaser needing to make this decision, I personally would not see that as valuable, as something that my family should pay 3 or 4 extra percentage points for every month, when in more than 20 years we haven't used it. Our suspicion is that there are many consumers in Vermont who feel that way, that the national network may be a nice to have, or perhaps when they're really feeling a lot of anxiety, it may seem important, but in reality, whose caregivers are surrounding them in their community, who are able to get all of the care they need with their local doctors, their local hospitals, and our 2 academic medical centers. And this product is really for them. So to answer the question, where the new customers are going to come from, we expect that they will come from within the existing ACA markets, in individual purchasers or small group purchasers who don't find the national network particularly valuable and are looking for more affordable care. These may be people who are on the bubble, sort of wondering if they can continue to offer benefits. It may be simply be people or organizations who are trying to improve their balance sheet a little bit, to lower the cost in this category, to stretch their precious dollars farther. And finally, I want to emphasize that Vermont Basic will have a comprehensive network. This is the entire Vermont network. As measured by 903, this is a complete network. It is not a limited network. It's more than adequate network. I mentioned last time that we used this network for over a decade in a family of products in the TVHP company, most notably our HMO. I just went back and looked for your reference so that you have a sense that this can work and work very well for Vermont consumers. At its high point, we had over 40,000 members in that product family. And between 2010 and 2014, which is really the last period that we were selling this product family actively, we had over 160,000 members enrolled in that time period in this network, all receiving excellent care. So the product will have complete network access. It will have all the essential health benefits covered. It comes with the same level of service and care that all Blue Cross Blue Shield members expect. And it comes with a comprehensive network that will meet the standards of 903. The product will be completely compliant with 0903. Oh, and one last question before I turn it over to Becky. I think Board Member Teachout, you asked last time, will customers switching into Vermont Basic from other ACA products cause a price hack because of risks, which when we talked to the actuaries about that, and they because each pool is rated entirely as a single pool, right? All the members, regardless of the benefit plan that they end up in eventually. So with that, if there's no questions for me, I will turn it over to Becky to talk more about the product design.
Thank you, Andrew. Good morning, Green Mountain Care Board. There are two components that make Vermont Basic unique to our current offerings. It's the network and plan structure. The network for our current product offerings includes our contracted providers and the National Blue Card Network for all types of services. Vermont Basic focuses on our contracted provider network, which includes neighboring counties in Massachusetts, New York, New Hampshire, including Dartmouth-Hitchcock. Vermont Basic will not include the national network for non-emergent care unless it's granted. Services outside of Vermont in an emergency or urgent care situation will be available. And access to obtain prescription nationwide remains available with Vermont Basic along with the current offerings. Could I have the next slide, Andrew, please?
Sorry, Becky, I'm having a little trouble
That's
advancing.
okay. Thank you.
The cursor is moving around, Becky.
All right, thank you. Can you go one more?
Yep. Brian,
Okay, sorry.
did you want to go here?
Yep, right there. Okay, that's good. Thank you. Vermont Basic reflects higher deductibles and out-of-pocket maximum in exchange with lower premiums. Vermont Basic does not share the same structure as the standard high deductible health plans with co-insurance after the deductible has been met. Vermont Basic is set up similar to the Vermont Select plans, as the deductible and out-of-pocket maximums are the same. Deductibles will vary between Vermont Basic and its counterpart, Vermont Select. And new for 2027, non-standard plan designs can vary between the individual and small group markets. This policy change allowed us to focus on the market need for Vermont Select plan design. What that means, like for individual, it's the premiums cost, which is tied to the elimination of the enhanced tax credit. And for the small group market, it's a rich plan design for employee benefits and retention for the employers. Vermont Basic will not include the deductible waiver for our defined wellness drugs compared to our other non-standard plan options. These medications will remain covered, but only subject to the deductible first. And with Vermont Basic, the gold and silver plans include a separate prescription drug maximum, which in 2027 is estimated to be $1,750. Okay, Andrew, I think it's good.
Thanks, Becky. So before I move on, a lot of information on this page. Any questions for Becky about the details of the benefits? Everybody good with wellness drugs and the change there?
What are wellness drugs?
Yeah, so wellness drugs are maintenance meds that we currently take the coverage and move it ahead of the deductible. So I had a list of them somewhere on my notes here, but maybe Becky, you could list a few off. But if you're using an inhaler, or cholesterol meds, or certain medications for chronic conditions that if you take them regularly, we know you're going to be well controlled. We consider those to be wellness drugs. And in some products, we move the coverage for those drugs before the deductible, so that the member can receive the drug without having to meet their whole deductible, or they get cost share assistance. But with these Vermont Basic plans, all the drugs will be subject to the deductible, wellness drugs and non-wellness drugs.
How much does that change impact the price point? That's fairly significant, and it seems like a funny policy decision.
It's not that significant. It's about 1% or a little bit less than a percentage of the savings come from making that change.
Can I ask a question, Chair Foster?
Yeah, everyone can. If people need to jump in, go ahead.
It's just related to the wellness drugs. I can't remember if insulin products and diabetic supplies are part of that.
Becky, can you help us out with that?
Yeah, so the diet, like insulin is, regardless if you met your deductible or not, it's subject to a $100 cap for a 30-day supply.
But what about all of the other stuff that goes along with being a diabetic? Not just the insulin,
Like the
the
test
strips and I can't remember what it all is, but there's a lot.
I believe it's subject to the deductible first for like durable medical equipment. Yep.
Do you need us to follow up any further on that?
No, I understand. Thank you.
Geez, I can't see. Okay. So finally, sorry, having a little trouble with the presentation, but I think Becky got all that information out. Finally, we'll talk a little bit about the marketing plan. And of course, this, like the pricing, is a little bit challenging because those don't get formally developed in the process until after this product approval step. But just to give you an overview of how this works, if you haven't been close to it, DFR reviews our certificates, and all of our QHP materials are reviewed and approved by DVA. This is a very collaborative process, very hands-on by those regulators. We work together to make sure that these materials are where they need to be. Unfortunately, they're not finalized until Q3, so I can't give you a nice mock-up. But we can talk about the principles and where some of the language is headed. As we discussed last time, it's extremely important to us for business reasons, for mission reasons, that the materials are very clear that Vermont Basic may not be for everyone. It's not for everyone, and we want members to be able to see that very clearly. So we'll have language in the certificate, right, of course, that defines this clearly and legally, but also in the marketing materials, front and center. Frankly, this is not going to be small print at the bottom corner of the back, not meant to be read. We want consumers, our salespeople will be trained on this. We'll make sure that the navigators are trained on this. We want consumers to ask these questions and really consider, is this the right product for me? You know, do you or any of your family members live, go to college, plan on spending time outside of Vermont beyond, trips, vacation, or business? Do you or your family members have a care relationship with providers outside of Vermont? Are you taking care of another family member outside of Vermont that might require you to be, residing somewhere else for a long period of time? We really want to get consumers to think about who this product is for and not have anybody mistakenly enroll in it. As a reminder, the network does extend into contiguous counties. So this does work for members who live, let's say, in Bennington or Brattleboro, where they're on the border. They have a complete community of providers around them. We talked a little bit last time, too, about the process for allowing care outside the network. For those who do need the national network, I just want to reinforce that this will be done in complete compliance with 903, and that work will be done by clinicians, not by an AI or by a business person like me, but done by clinicians who can really understand, is this service available in Vermont, or do we need to help this person find it somewhere else in the national network? And then the last little bit on this slide, I think, is just giving a sense of what the certificate language would look like. Very specific. Certain situations may be paid for, but some will not. And we want consumers to know what they're buying. So I'll stop there and just finally say that we know that a lot of members value the national network, and we're proud to continue to offer a number of products, a family of products for those members We do believe that there are some who are really struggling with cost, who don't value that national network, and who get great care, fulsome care here in Vermont from the Vermont network. We've offered these products or networks or products built on this network before. They've been very popular and very successful, and we're hopeful that Vermont Basic will be a valuable choice for consumers and small businesses on the exchanges this year. Thank you.
Okay, I'll open up to board member questions. I'll start with member Merman.
Yeah, thanks, Andrew. So I guess this is an interesting product, and I think that it's been interesting to think about this product in Vermont in the QHP market and available for the individual market. I think one of the things that you talk about is that this product is going to have a lower AV value, and that the real benefit to the premium comes from the AV value reduction outweighed compared to the narrower network, and maybe some of it is selection. And I guess when I look at this network and listening to you talk about it, I think you're sort of really trying to say this is a product that would work for individuals who, probably don't have asthma and aren't looking for a product that can, make it easy for them to seek care farther out of state than the contiguous counties. So, not Dartmouth, but moving beyond down there towards Boston. And I believe I don't know if Albany is technically in a contiguous county, if Albany Medical Center is. So, okay. So I guess what I'm trying to understand is, have you modeled what this product will do, the basic product does to the select premiums, insofar as that the basic product would likely select individuals with lower health spending, healthier individuals, and then the select product will be left with individuals with more medical problems or needs or claims? And have you modeled the premium impact to the select product? And what is it?
Yeah, I think if I'm understanding your question, it's similar to the question that member Teachout asked last time. So we did all of those members get rated together as a single risk pool. So there really isn't that sort of selection issue. It's not like the select gold is a risk pool and basic gold is a risk pool. And if select gold gets less healthy because healthy members went to basic, then select gold gets more expensive. They're all rated together as a single risk pool. So we won't have that sort of selection pricing issue here.
Okay, thanks. Maybe I just needed to ask it for myself to understand it. So I appreciate you repeating Sarah's prior question. I guess that's sort of my big question. My statement on this is I think it's a really challenging time right now. When I looked at the numbers the other day, I think in 2025 there were something like 1,200 or 1,500 people on the individual market without subsidies, and this year it's over 6,000. So 4 to 5 times the number of individuals in Vermont on the individual market without subsidies. And for those people, a 7 to 9% premium reduction, I think, could be impactful for many of them. So I think this comes down to supporting whether or not we support choice in the market for individuals to be able to make decisions that work best for them. And for, like you said, for many people, this is probably not the right product because of the higher deductibles, the way the deductible works with the wellness meds, and the restriction of the network. But for many people, it might make sense. And so I think it's a question of, do we want more choices, or do we feel that we need to ensure that the products that are on the individual marketplace, are completely robust, and I guess in my estimation, I sort of fall down on the choice side of this, and I think that's where I land. I think many employer-sponsored plans that we don't regulate have networks that are much narrower, and a lot of Vermonters are managing those situations. I'd like the opportunity to offer a lower priced product to Vermonters at this time.
Member Teachout, any questions or comments?
Yeah, thank you. I just wanted to dig a little deeper in what are the services out of state that are more expensive that will be excluded from this network? Because we know that Vermont hospitals and specialists here in Vermont are actually quite expensive, even compared to facilities out of state. So is it because we're envisioning reference-based pricing caps in the QHP market next year that really makes the price differential more valuable? Or are there certain services, and I'm thinking, so just tell me if I'm right or wrong, residential substance use care, facilities out of state? Are we talking specialty hospitals for oncology? Can you just give me a list of the types of things?
Yeah, I'll ask the actuaries to pull some examples for us. That unfortunately, that's going to have to be a follow-up. But when I talk to them about how this works, because we all sitting around the table immediately have the same thought. Well, why would the national network be cheaper? Or shouldn't it be cheaper? Right? Things are so expensive here in Vermont. What are we missing? So it's essentially what the team explained is that they simply looked at actual data about what the cost of care looks like for members who utilize the national network versus those who just utilize the Vermont network. And the cost savings seems to come more from the profile of those members than it does any particular service. So at no point did we sit around and say, wow, this, once we don't have to pay for this on the national network anymore, this will get a lot cheaper. We didn't have like a hit list of services that are causing problems. It's just the way that members tend to use services. Those who stay local and get all of their care in Vermont just tend to be a little less spendy than those who are often accessing the national network. They just spending more.
Great. And then I do have another question about the prior authorization. And I think you said on one of the slides, it's for specialists who are not in network. What about wait times? So we may have lots of specialists here in Vermont, but the wait time to actually see those specialists could be extremely long.
Yeah. Well, I've been thinking about this one because we talked about it last time. So if the situation is I need this test or procedure in the next 2 months and it's emergent to be done in that amount of time, and it can't be done in Vermont, well, two things. Of course, we will prior approve that to somewhere that it can get done. But more importantly, I think we'll be talking with our quality department to be talking with the providers involved about how can we be to a place where we're telling Vermonters that we can't give them like life-saving care in Vermont when they need it, right? And we haven't heard that story. We've certainly heard, my kid needs mental health support and we can't get an appointment for a year. My friend is trying to get a primary care physician, and we hear all the time. I needed this life-saving procedure in 2 months, and no one in Vermont was willing to give it to me in that amount of time. I don't think we hear that particular problem. So I'm not as worried about that situation. But of course, we will do what is right for the member. In an emergent situation, the member needs care, right? And our care manager will help them find it, honestly. That's how that would go. As far as routine care wait times, I don't think we would accept the benefits and allow that to the national network. So I need a primary care physician. I can't get on a panel for 7 months. I'd like to go see one in Conway. I don't think we would approve that.
Okay, thank you. And And I just to state it, I think some of my concerns are around cancer screening. So it seems like preventive care until you have cancer, right? So maybe if those are take a very long time in network and you're not going to allow it to be done somewhere else. But I don't know how often that actually happens. I want to press again on the issue of separating the pool by morbidity and increasing the costs. I get that, we're community rated. I get that, like, between MVP and Blue Cross, there's risk adjustment, to take care of the difference in risk between the two carriers. But when you're separating amongst your own pool of lives, so if you're not actually attracting new members to your plans, you're just kind of shifting between existing and members by morbidity, it seems like it's going to have to increase the premiums for the remaining people because you're lowering them for these others. There can't be just a win, and unless you're denying a lot of care. I don't know how this works.
Well, I'm not an actuary, and I didn't stay at a Holiday Inn Express recently, so I can only go so far here. But I guess to me, it helps to think about it in the abstract. So I imagine, like, the small group pool, let's say last year spent $1 million on claims. That was all the membership in 2024. They spent $1 million. When the actuaries project the rates for 2026, they will use that $1 million to develop those rates. That will be trended forward, right? Now, the product mix, where the enrollment is in the product mix, may affect that trending a little bit, right? So I'm sure it's not the case that members in those products like have absolutely zero impact on any factor. But the reality is that $1 million is being pulled forward and rated for 2026, regardless of what products those members were in. It's the same amount, right? And the risk that you're talking about, I actually think accrues to the carrier, not to the market or the member. So if in the end, and you could talk more to Martine and Ruth about this, I'm sure they love me volunteering hearing topics, but if the membership mix that actually lands, right, when March comes and we look back and say, where did all the members land? If the membership mix is very different from where we thought it was, we may be bringing in a little bit less or a little bit more premium than we expected to bring in. It's like we sold a little more bronze than we thought and less gold. We're going to have less premium dollars coming in than we anticipated, and that can maybe mean that we've underfunded admin a little bit or something like that. But I don't think any of that risk accrues back to the marketplace. Like we don't have that sort of adverse selection hopping game, right, that we've seen in the past in small group where each pool is rated individually. So when you have that movement, it really does cause the prices to move artificially just because the members moved.
Okay, thank you. And then the last thing I'm going to say is more of a statement, not expecting an answer from you. But I get that a lot of the value here is from adjusting the AV values of the plan. So you're shifting more of the cost onto the patient and the family. And so that really benefits people who on average use less care. And then those who choose poorly and end up needing more care are kind of the losers in this situation. And I think that these plans really increase the gamble that families take every year with their healthcare needs and costs. And I get that that's already happening in the system, and how much we allow, this is just allowing that to happen to a larger degree. But it's something that I'm concerned about, quite frankly. And I guess, there's different ways to think about it. You're just letting people choose different options, or are you actually encouraging people who are currently not buying plans to enter the marketplace? That would, perhaps be beneficial. But the thing is, none of these plans are actually the lowest plans in the marketplace. Both the Healthcare Advocates Office didn't see this, underpricing the silver benchmark plan. So there already are lower priced plans than what these are, or it appears to be. So that's another way I'm kind of trying to think through the implications here.
Yeah,
the-
it's very challenging without having like all the final prices to put on the table in front of us. I completely agree with you. And I would just say about the level of choice, I mean, the flip side, and I think some of the underwriting theory that would sort of argue that the more choice you give a pool of people, in some ways, the more you serve them, the less you're asking them to sort of pool their risk choices, right? If we had only 2,000 to two deductibles, let's say a 2,000 and a 10,000, a lot of people are going to be unhappy. I don't need 2,000, that's way too much. 10,000, that's way too high. The right number for me is 4,500. Right? So the more deductible levels we add, in some ways, the more we enable people to choose the perfect risk product or the perfect product to match their amount of risk. Right? We give them more options, and they can really, like, I know $4,500 is the deductible where I win. 48 I lose, 42 I lose, but 45, that's my winner. Yeah.
Thanks. Yeah, I just have to push
Perfect
back because there
information.
have to be winners and losers if it's going to meet the AV value on average, right? So if it's a 58% bronze plan AV value, 58% of the costs on average are covered by the insurer, and the remainder is covered by the families on average. So there's winners and losers across the board. Some people will do better and some people will end up paying more.
Right. Yep.
I'm all set. Thank you, Chair Foster.
Thank you. Member Walsh?
Thank you, Chair. And good morning, Andrew. I want to just start off by thanking you for, I can tell you've made a big effort to be very clear about the limitations of this plan in your presentation and the communication, and I really appreciate that. I also appreciate the desire to be innovative and understanding what Vermonters are going through with the removal of the subsidies, the different things that are happening nationwide. And I'm honestly, I feel conflicted here because I believe in what you've said and what Member Merman said about the importance of choice. But I've also found the other board members' questions informative. And I don't know that I'd rely on the word gamble so much, but this is a plan which individuals are choosing a lower premium, but a bigger risk. And when I try to look at that risk and quantify it, we've been looking at this for a short time. We haven't been able to model it in different ways, but the risk that Vermonters would be choosing includes the fact that they live in a small state with a couple handfuls of hospitals, a couple handfuls of places to choose from. Those places tend to be very high priced relative to other states, even nearby states. And access within our state is problematic. So, and I don't know, I think consumers are very smart. They can do their kitchen table economic analyses the way you were describing, but I don't know if they understand the risk of the size from the small state and the small number of providers and the access issue. And those things concern me. And so I tend to be inclined to want to look at this more. I was pleased about your transparency with there's no harm to Blue Cross if we said come back in a year. I'm trying to listen and learn from other board members, and these are the things that I'm trying to weigh. I know there's no clear question in that, but that's I guess that's sharing where I am at the moment. So,
Thank you. Thank you, Tom. And Member Holmes.
Thank you.
Sorry, Andrew.
Oh, Andrew, were you going to answer? Sorry. Or did I just lose Andrew?
Well, I understand that it wasn't quite a question and I don't quite have an answer, but I think we take better care of people here in Vermont than we might be giving the system credit for. And I know we have our challenges. I'm sure every state health system has its challenges, but I don't think we have a lot of care going out of state because it simply can't be provided here. We have some of it is by preference, but as I said, we ran this product type on this network for over a decade. It was very successful. It was our best seller in large group and small group. We were able to put the processes in place to make sure people got the care that they needed in those relatively rare situations where they really did have to go out of Vermont.
Yeah, I heard you mention that heard it mentioned last week and earlier today, and I thank you for it. It's compelling evidence that this is a product that people have found value in the past, and I appreciate hearing that.
Am I up, Chair Foster?
Yes, please.
All right, great. Thanks, Andrew. And I actually just have one question for you, and it relates to Member Teachout's questions, and I think what you're hearing from other board members about wait times. And you commented that we have more than adequate. This would be a more than adequate network. And when I think about that, I think, yes, if we think about it as the number of specialists and the type of care that between Dartmouth and UVM are available, yes, the straight up list of specialists available. But when you factor in wait times, I think that is a concern. And I know Member Teachout addressed that already. But I wanted to ask you a question more about the decision making to allow out of network. So I think you probably are well aware that CMS recently established wait time standards that was tied to network adequacy for the federal exchanges, which of course we're not on. But that, the point there was that, the onus was on the carrier to demonstrate adequate timely access or they lose certification. And, the wait times for behavioral health was 10 business days. The wait times for primary care was 15 days. And the wait times for non-urgent specialty care is 30 days. And they're required to have a third party do secret shopper studies to ensure that actually there's 90% compliance, right, with those wait times. So, those would be hard for our Vermont provider network to meet 90% of the time. I think we can all agree to that. I don't think very many people can get a non-urgent specialty care appointment in 30 days for many specialties in the state. But what I wanted to ask you was, it would be helpful for us to understand, would you consider adding your own standardization of wait time in your determination of service availability within our network in your prior authorization process? You see what I'm saying there? So that there's so that people can understand and maybe 30 days would be too conservative, but if you have to wait a year for a neurology appointment, I would say that is actually not an adequate network in the state. And even if it's, life-threatening, you don't know if it's life-threatening or not unless you actually have the appointment. So that would be helpful for me to understand, is if you would consider Blue Cross Blue Shield in this plan that has a narrow network in a state that has exceedingly long wait times, to provide consumers with an understanding of how, when they want to seek a prior authorization to go out of network, how wait times would factor into that decision.
Yeah, honestly, I don't think we've looked at wait times for non-emergent care. Our energy has really been focused on making sure we have a really clear set of definitions for when urgent and emergent care are always allowed wherever you are, right? We always pay for that, but really understanding the rules about what is travel versus what is temporary residence. Right. So if you're, that's where we focused our energy with DFR, because 0903 really sort of lays out a whole series of rules to define how this is done. And it's important that the product comply with that rule. None of our energy has really been spent on thinking about sort of the wait times for those normal conditions, I guess, when you're not traveling or you're not in an urgent emergent situation. And I don't think realistically we could do that quickly. I think what you're describing is a big project, and would be very, very difficult to measure. Getting data back from providers about information like, is your panel open? What are your wait times? That's one of the more challenging touch points in the system nationally. It's very hard to do.
Yeah, I guess what I'm asking more so is it would be helpful to see what is your prior authorization process, and would you be willing to self-impose some standards where the patient who is facing exceedingly long, and I guess that is, to be determined, but I would love to see what your determination was of exceedingly long access barriers to getting care, and that would be an expedited prior authorization. That's what I'm asking about, is your internal process. What would you be willing to commit to so that there's less uncertainty on the patient side about, if I can't get into a neurologist within 45 days, 90 days, whatever, I'm automatically going to be allowed out of network for this. That's what I'm asking more about, is your internal prior authorization process.
Yeah, I'm sorry that I'm looking a little confused because we hadn't thought really about this, and it's not a question that I think I can answer on the fly. But my sense is we could not do that easily or quickly, and we would have to spend a lot of time to ensure that even if we could do it, that it didn't undo the pricing maneuver that we just made. And it just strikes me as I'm thinking about how we would collect all of that information and do that analysis, that it's not easy and it would not happen quickly. Certainly not for 27. Also, it strikes me that we may introduce other problems that we would have to wrestle with, not necessarily bad things, but issues, right? We don't advertise, use the national network if you're having trouble with your access. Haven't really thought about that. And I'm not sure a lot of Vermonters think to do that. I need primary care, I can't get it here, so I'll go to Concord or Manchester. In some ways, doing what you're suggesting would almost be sort of signaling to Vermont, if you have an access problem, go out of Vermont, get your care somewhere else. And
Andrew, I know a lot of people that do that, actually. I know a lot of people that do that.
We would really have to sort of wrestle with all of that and do some modeling and really think about like what would that mean. So I think I'm saying no. I'm sorry. After chewing on all of that, I don't think it's possible.
Okay.
Anyway.
That was my only question, Chair Foster.
Yeah, I just want to follow up on that one. Mr. Garland, you said in response to Member Holmes' suggestion that you would, quote, worry it would undo the pricing maneuver you just made. So what did you mean by that?
Right. So the data tells us, right, that people who stay in Vermont for their care primarily are using, about 3% less expensive. Like that network bill leads to about 3% lower cost. If we were to add this feature that says, well, if you can't get your mental health prescription or your mental health visit in 15 days, we're going to do a PA and allow you to go out into the national network for that, that may change the way, that may change that cost picture such that if we were to go out 2 or 3 years and then we look back at it again, we would say, oh, look, those people who stayed local are no longer 3% less expensive because a lot of them had PAs to use the national network because of the access challenge. So it may be that we would just unintentionally erode the affordability win by leveraging the local network. That's all.
And have you considered, so you're right. I mean, we have an access versus an affordability tension here, where if we improve the access by allowing people to go out of state, it can hurt the affordability strategy here, which I respect and understand. But on the access side, we also have risk of poor health outcomes. I mean, these delays in care, I think we've all have experienced, I'm sure many other people have in the state, and they do impact outcomes. So have you considered that, the restriction in timely access that this could create and its impact on outcomes?
No, I don't think we saw anything about this product design fundamentally making that problem worse. And we certainly didn't jump into this with the intention of sort of unpacking Vermont's access challenge. The challenge we set ourselves, and it was only a few months ago, people are really struggling with these prices. We have a lot of things happening on the provider payment side. That's a positive force that's moving things in the right direction. Can we find any force on the product side to help move things in a better direction? Could we find a way to get about a 10% lower premium? And we went hunting, right? What are the things that can move these rates? Well, we can move the cost share. Maybe we could move the drug. That turns out to be really, really complicated and slow and something to look at, but for the distant future. And we can move the network, right? That is something we know we can do. We've done it before, highly successful. So that's how we really got here. I'm assuming if you choose this product, you know where you're getting your care, and you've got it covered. Either you don't really need care, or you don't need very much of it, or I've got my PCP, my endocrinologist, and my pulmonologist. I'm set. I have what I need here in Vermont. I'm getting the care, that I need.
Okay, great. Member Teachout?
Ask one more clarifying question.
Please.
Just to clarify, because when I asked you about it, were there certain places or certain types of services that were more expensive? And you said more, it's the profile of the patient. So it's less about trying to redirect people to different sites of care, to less expensive sites of care, which would be my preference, like try and move people to places where it's more affordable, and more about segregating between more expensive and less expensive people.
No, it's more about, for those people who don't find that buy-up, which the national network is a buy-up, who don't find that buy-up particularly valuable, can we take that buy-up off the table and offer you a slightly lower product or price product? So a good analogy, for the first time ever, I considered a two-wheel drive car recently because I live on pavement now and all my commuting is on pavement. I only have one hill to deal with and it's well plowed, and well, maybe I don't need all-wheel drive anymore. I could go with the front-wheel drive car. It's not a great analogy, but I think there's a sort of similarity between all-wheel drive and the national network, right? It's an added feature for a lot of people. It's very valuable. You want it. You're willing to pay for it. Some people look at it and say, really?
Okay, thank you.
Great. Ms. Beliveau, I'll turn it to you.
Great, thank you.
I don't need
And
like that.
I just need a second to present in Teams. Is everyone else hearing that echo?
Not anymore. I think it stopped.
Okay, great. Phew. Okay. Teams. All right. So yes, I'm Laura Beliveau, a staff attorney here at the Green Mountain Care Board. Here to provide some staff comments on Blue Cross's Vermont Basic proposal. And I just want to say thank you to our colleagues at DFR and DEVA, and also our actuaries at LNE for support. This was a lot of information to try to distill in a short amount of time. So I really do appreciate their working with us on tight turnarounds. So slide. Blue Cross just presented on the Vermont Basic proposal. I'll note again, the most significant differences are that Vermont Basic restricts access to the national provider network and sets the AV value at the low end for each meta level. Here is a reminder of the non-standard plan approval criteria adopted by the board in 2020. I'll go through each of those pretty briefly. The first criterion is whether the proposal presents a different deductible and MOOP structure, which Vermont Basic does, and it places the plans at the low end of each AV level. The structure is anticipated to reduce premiums. The second criterion doesn't apply here. The third criterion is plan structure difference, which in this instance is similar to the first criterion. The fourth criterion is innovation, the restriction of the national network in order to reduce those claims costs is a new approach for Blue Cross and the Vermont market as a whole. The fifth and final criterion is whether the proposal adds value to the Vermont marketplace. In this instance, it's really the heart of the matter, whether the premium difference for Vermont Basic is worth the restriction of the national network and the lower AVs. DVA has provided a recommendation, and it's here on the slide. They have 2 points of concern. The first is whether the network restriction itself will provide meaningful reduction to premiums on top of the savings generated by the lower actuarial values. And the second is the adequacy of the marketing campaign to ensure consumers understand the important aspects of Vermont Basic in comparison to other QHPs. So if meaningful premium savings from the network restrictions cannot be demonstrated, DVA would not certify the Vermont Basic plans. DFR's recommendation is here. First is that the proposal is consistent with state and federal law. Second, DFR observes that Vermont Basic is unique in the market with its limitation on out-of-state care. However, DFR does not yet have information on the impact of this difference on providers and on costs. Vermont Basic has to comply with DFR's regulations as was referred to earlier, including network adequacy. DFR and Blue Cross are still in discussions on this, but DFR seems to believe that the details can be resolved. We've discussed this proposal with L&E. L&E agrees a 3 percentage point impact on premiums from the network restrictions could be considered meaningful. They don't have enough information yet to determine whether 3% is an appropriate assumption, but they would be able to pursue that during our rate review proceedings. L&E is also concerned about whether the proposal will attract new members to Blue Cross because there could be negative revenue implications if it does not, which I think was addressed a little bit earlier. Here are a list of pros and cons. I think the pros have been covered pretty well. The cons that we see are we don't have enough information to confirm the network restriction savings. There's a risk to Blue Cross of lower revenues without an offsetting reduction in claims. The plan seems unlikely to attract new members to the market in general, and perhaps to Blue Cross in particular, because MVP does already have lower cost plans. So trying to put this together, DVA has said it won't certify the Vermont Basic plans if meaningful savings from the network restrictions have not been shown. And DVA does have, by statute, the final discretion to certify plans. However, talked to our actuaries who pointed out that DIVA certification, which runs August 13th through September 15th, is actually difficult from a rate review perspective in terms of the final documents that the carriers have to prepare and submit immediately following the board's rate review order. And our order this year will be on August 10th. So if the board wants to defer its decision or approve with a caveat that Blue Cross needs to demonstrate that meaningful premium savings from network restrictions, it would be best for the board to do two things. The first is, I think for clarity, is define what is meaningful now. As I said, our actuaries think 3 percentage points is a good starting point for what would be meaningful. And second, set a deadline for the board to be the ones to make the final determination. And that should really be no later than day 90. Day 60 is also a good milestone for the determination in terms of the carrier being able to update its compliance documents, its carrier calculation to reflect the inclusion or not of Vermont Basic in its plan portfolio. So the staff recommendation could go one of two ways. First, you could deny, but without prejudice, meaning Blue Cross could bring the same plan back next year, but ideally with more information on the premium impact of the network restriction and the plan for marketing. Or you could defer your decision with the requirement that Blue Cross demonstrate that the network restrictions impact on premium is whatever percentage point or greater, and that it has prepared a robust marketing campaign and specified that the board will issue its decision on day 60 or day 90. And I prepared suggested motion language reflecting those recommendations as a starting place.
Thank you,
Thank you,
Laura.
Ms.
This is
Sullivan.
Tom.
Oh, go ahead, Tom.
Thank you. On slide 11, I was just starting to read the bottom when you moved forward. I'm not sure we covered the full. All right, thank you.
Can you move to the motion slide? Chair Foster, should I start us off? Do you need somebody to start the conversation, or do you?
Yeah,
want to
sure.
start?
Yeah, that'd be great if you would, but I have one question before that maybe was
Okay.
said and I missed it, but just, I think this is for Mr. Garland or Blue Cross. What is the current estimate of how the pricing for this would compare to the lowest priced MVP plan?
Yeah, we don't have an estimate there at this point, but honestly, we'll know in a couple of days. But our assumption is that it is possible that these products will be more expensive than some MVP plans that are similar and perhaps with even better benefits. You know, the difficult thing about introducing new products in this environment is that it may take a couple of years before we get to a price point, right, relative to everything else that's happening in the market, where these products are going to make the most sense. But if we don't start and get them into the market, we're not going to get there.
So why would an informed consumer buy this instead of the MVP product?
You know, there's a possibility that the market will be relatively small this first year. And I don't mean to sound arrogant when I say this, but there are a number of consumers who are focused on Blue Cross. They're looking for a Blue Cross plan. They understand what we're about, what our service model is like, and that's what they want to buy. So this product will undoubtedly appeal to some of them who are simply looking at it and saying, I don't need this high a deductible or this low a deductible. I don't need this national network. I want to stay blue. This lowers my monthly cost. I'm going to do this. We may not invite a lot of people switching from other payers or other plans early on. That's quite possible.
Okay, thanks. Thanks, Member Holmes.
Okay. So I guess where I'm sitting, and I guess I'll just put this out there, I do appreciate the effort here of Blue Cross Blue Shield to try and make something, be innovative here and make something more affordable. In general, I tend to lean towards more consumer choice out there, and certainly greater affordability. So I am in favor of the first motion here. I think we can take a cautious approach. So I would vote in favor of deferring approval here and giving time for Blue Cross Blue Shield to show us the independent effect of the network restriction. I like the language here, but I wanted to add something. So what I would say is I'm going to propose this motion here, which is I move to defer approval of Blue Cross Blue Shield of Vermont's proposed Vermont Basic Non-Standard Plans as filed with the Department of Financial Regulation. The decision will be made on or before, and I'm going to suggest August 10th, 2026. Approval will be contingent on demonstration of at least 3% or 3% or greater premium reduction attributable to the network restriction, a robust marketing campaign, and a prior approval policy that factors in wait times. So that would, alleviate some of my concerns about the wait times, and I would like to just see what that looks like. I recognize from Mr. Garland that may be a challenge, but that would make me feel more comfortable with eventual approval of this plan. So that's my motion.
Second that motion.
Thank you, Member Holmes and Merman. And I'll open up to board member deliberations. If you don't mind, I'll call on you because I'm myself just a little torn on this one. But I'll start with Member Teachout. What's your perspective on this?
Sure, thank you. So I would prefer to deny it this year without prejudice. Give Blue Cross more time to work through the details here. I appreciate Member Holmes' proposal on a wait times criteria for prior auth, but I heard Mr. Garland say that was probably unlikely to be able to accomplish, certainly before August. So I really do think that this needs more time to be developed. But again, I do appreciate the innovation. Just to further elaborate a little bit on why I would deny this year plans with lower premiums, because that's a really tough choice right now in this current environment. There still are lower premiums in this market. So while there's not enough information to really tell what's going on, it doesn't appear that these will be the lowest priced plans. And that's also the conclusion the Healthcare Advocate came to last week when they said that this wouldn't underprice the existing benchmark lowest cost silver plan, although, that's not a guarantee. It could be lower in some and not in others. I still have concerns about separating the risk pool and actually the risk to Blue Cross, if that's what it ends up being. I think limiting to only Vermont-based network when our largest local hospital with most of the specialists in the state is really struggling with long wait times seems very problematic. And I'm also concerned with sort of like what I said before, the gamble that families have to take with their healthcare needs and costs. This just increases the risks for those families, and certainly it will be beneficial to some, but not beneficial to others. I believe Vermont's affordability challenge is predominantly about high prices for hospital services, and we need to focus on lowering prices to help everyone and remain focused on that goal. So that's where I stand. Thank you.
Thank you. Member Walsh.
Thank you. I think having listened to the weight of things, there's many times we come to a place in this discussion where we're saying we don't know enough. We want to know more. I'm particularly concerned about if many people are drawn to these plans in the name of affordability, what that does to the old plans that they're leaving. That has we've been reassured by Blue Cross that should not impact, but it stretches my imagination to come to a place where it would not impact those plans. As I mentioned earlier, I'm concerned about the small size of our state, the high prices within the state, and the wait time issue, where we would be approving a narrow network that is high priced and difficult to use. These plans in general, when people do sign up for them, when they do make their personal decision about it, the evidence from around the country over a number of years is that people then hope and do everything they can not to use medical care. And that ends up being more expensive later for them and for the rest of the state and for other premium payers. So I understand and support the desire to do something about affordability, but this particular approach offers an illusion of affordability. Over time, these plans have not proven to be more affordable. They shift cost onto individuals. For that reason, I was more inclined to deny and ask Blue Cross to come back next year with more information about how this plan might play out.
Thank you. Any additional comment from Member Holmes or Merman on this issue at this time? And then I'm going to go to the healthcare advocate.
Yeah, at first one, I completely agree with Member Teachout on the problem. One of the major problems driving healthcare, the probably largest problem driving healthcare expenditure in Vermont, you can cut it different ways, is high prices or receiving care at places that are high prices. And so I completely agree that the main thrust of policy efforts, regulatory efforts should be in trying to figure out how to reduce prices and encourage care to be, and have options for care to be delivered at places with lower prices. I guess I try to balance that with the people who I speak with who are unsubsidized this year and have to pay full commercial premiums in the individual market, and having an option that would be less would be good. Now, maybe it's less than MVP, maybe it's not less than MVP. I don't think we have premium numbers yet. And when I look at MVP's website, and there's nobody here from MVP to comment on this, and I don't feel comfortable asking Mr. Garland or Ms. Beliveau to comment on MVP's plan specifically, but they cite an example of a college student off at college, and they can receive emergency care there, but they should call for prior approval before receiving other care. So to me, that doesn't sound, other than the MVP network, which is Vermont and New York, and I don't know entirely the New York network. It sounds kind of similar, except for it includes New York. And so for a lot of people in Vermont that don't go to New York direction for care, it seems very similar to this. So I don't know. I don't know. But I do think we have probably one of the top few most consolidated provider networks in the country, and we have one of the top most consolidated insurance networks in the country. And I think while this doesn't increase the number of carriers, it increases the plan options, and I think that is kind of the best we can do given what we have. So I think for those various reasons, I support the motion. I think like everyone else, we I'd sure love to see premiums that are substantially lower than 3 to 9% available for people in Vermont.
The only thing I'll add, Chair Foster, is all we're doing with this motion is deferring a decision until August, getting more information and deciding in August. So that's the way I look at this. There's more information that we will receive. The pricing will come out in the next, short term, and we'll have a lot more information. So to me, this is just a little bit of kicking the can down the road and gathering more information. And ultimately, DEVA will certify it or not. And they've asked us to gather some of this information, so they will also be weighing in. So this doesn't feel as big a decision, I think, as maybe others may think it is. It's a move to defer and gather more information.
Why don't I turn to the healthcare advocate?
So Chair, thank you. We have no comments other than we did last week. I will say I don't have any opinion one way or the other, but Member Merman, I believe, and again, it's ask MVP, but I believe MVP uses Cigna's rental network in the same way that Blue Cross uses the National Blue Cross rental network. So it's like, it's the rental network that's going away. So it's not like that statement on MVP's website really confused me, but at least in rate review, and this is last year, and every year I've worked for the HCA, they use Cigna's rental network. And I would just say to Mr. Garland, and I would imagine you wouldn't know this, or Blue Cross might not see this, because SHIP funding, so the funding for Medicare assisting, open enroll, and that Medicare open enrollment overlaps by about 2 weeks with QHP open enrollment, and community organizations and frontline organizations are really struggling right now. And, the volume of people, folks, and our office helps is shocking. I mean, I think last year during open enrollment, we answered the amount of calls we would normally answer in 6 months in a month and a quarter period. So I just want to, however you go forward with the marketing plan, I think it needs to recognize that it needs to happen much sooner probably than you think, because community organizations are really struggling to deal with a bunch of the federal cuts, including cuts to the Navigator program, but also now cuts to the SHIP program for Medicare, and it's very overwhelming. And I know it's not just us. Thank you.
Thanks, Mr. Schulteis. Public comment via raise the hand. Walter.
Hey, Owen, thanks a lot. I don't know why my camera's not working, but it's not. Members Teachout and Walsh really covered what was simmering and brewing in my mind. But I want to ask a question. In what kind of a bubble are deductibles like 4,000 and change, 7,000 and change, and 11,000 and change considered affordable? As someone on the street who would have to purchase one of these plans, there is no way that any one of those deductibles is affordable. So I'm often curious how you think that something like this is affordable. And then, of course, what is affordable and to whom? Because someone said earlier, there'll be few people will be looking at this plan at these plans as anything but a stopgap measure and using and paying for healthcare that they can't use, which seems like it's the purpose of these plans.
Thank you, Walter. Another public comment? Okay, I'm gonna see if we can take a 15-minute break just so we can get Member Holmes's proposed language on the document here so we can see it together. And I'm gonna add, I might actually tweak it and add something and make a different motion, which would be Member Holmes's motion with a little more detail around what the marketing campaign would need to include. I am concerned about uninformed buyers buying this and really making sure there's appropriate disclosure. Because if the MVP plan is more robust, better deductibles, more affordable, I want consumers to make sure that they know that and that they're choosing, for Mr. Garland's point, there are people that very much favor Blue Cross for any number of reasons of the quality of the company or whatever it may be. But I want them to know that that's what they're choosing. I want it to be clear. So I wouldn't mind trying to work on a little bit of language about the marketing campaign. Member Walsh, I see your hand is up.
Yeah, I raised it. I was going to ask about a friendly amendment. Last week, you asked about the marketing campaign, and I was wondering if we could add that to Member Holmes's motion, that we actually see a mock-up of what that would look like. We've not seen that yet. Didn't see it this week. I think that's a key thing. So,
Okay,
thank you.
great. So why don't we take a 17-minute break? We'll try and work on some language for a motion, and we'll come back at 12:20. Thank you. Ms. Belleville, are you all set?
I am. I just need to 17. I'm gonna have to forward through my slides. Yeah, no. Yes. Slide 17. There we go.
Great. Okay, we can go back on. Resume our hearing. I am going to introduce some additional language that is consistent, I think, with what Member Holmes had proposed, so that we can all read it and see it, and then some additional language around what I had said at the end. So I'll read this, and then I'll ask members Holmes and Merman, who moved and seconded the prior motion, if they'll accept this as a friendly amendment. So I'll go ahead and read it. I move to defer approval of Blue Cross Blue Shield of Vermont's proposed Vermont Basic Non-Standard Plans as filed with the Department of Financial Regulation. The decision will be made on or before August 10th, 2026. Approval will be contingent on demonstration of a 3% or greater premium reduction attributable to the network restriction and the submission and GMCB approval of a prior authorization process that permits out-of-network care for patients who cannot timely access care in Vermont, and a robust, plain language, and clear marketing campaign. The marketing campaign must compare Vermont basic pricing and network restrictions, including access to out-of-state providers, to the lowest price competitor plans. The plan must disclose that access to only Vermont providers in certain circumstances can implicate challenges to timely access to care. The marketing and prior authorization submissions shall be submitted with the carrier's pre-filed testimony.
I accept the friendly amendment, Chair Foster.
Thank you. And Member Merman, if you have a moment to think about this and let us know how you feel.
I have all sorts of feelings, Chair Foster, but about this specifically, I guess my big feeling, if we're going to talk about feelings, is disappointment with the reality of this statement. The second sentence to the end is that accessing only Vermont providers in circumstances can implicate challenges to accessing timely care, and it's in the greater context, I think that is a challenge for a lot of people in Vermont because of geography, transportation, and just logistics of life, and getting referred places outside of Vermont. So I guess that's my feeling. Do I support the motion language? I think is probably the real question at hand. And I do think this is going to create some challenges for Blue Cross, and I do think that we really probably, as a community, need efficient ways to get access if we can't provide it in state, out of state, in a way that supports Vermonters accessing care in an equitable way, which I think transportation does provide a problem. So, anyways, long story short is I can accept this amendment, and I support it.
Okay. I'll open up for additional board member discussion on the motion that is now before us.
This is Sarah. I appreciate the effort to protect patients here, but I continue to believe that this is a Band-Aid over a much bigger wound. And I don't believe my concerns will be alleviated by sort of the extra pieces that you've added here. So I continue to be a no.
Understood. Thank you. And Member Walsh.
Yeah, thank you for the opportunity. I appreciate the added language. I still have notable concerns, but I was persuaded by Member Holmes and her point that this allows time for Blue Cross to bring forward more material that may assuage some of my remaining concerns. So I could be in favor of this motion as written, with the understanding that there's still more steps before final approval of the basic Blue.
And I'll turn to the healthcare advocate and public comment.
No comment from us, Chair.
Great, thank you, Mr. Schultheis. Any public comment? Okay. Ms. Beliveau, could I ask you to take a roll call vote on the motion?
Yes. Member Walsh,
Yes, on this proposal, on this motion.
Member Teachout,
No.
Member Holmes,
Yes.
Member Merman,
Yes.
and Chair Foster.
Yes. Thank you. And the motion carries. And thanks for Blue Cross for presenting this and answering our questions today. I think this was an interesting process. We know there's a lot of work done on this, and I think this provides the opportunity for some of the additional work that remained outstanding, I think, to really evaluate this to be done. So thank you all for working on it and for presenting, and we look forward to seeing you soon in your work with DVHA.
Thank you all.
Thank you. I believe those are the only agenda items for today. Is there any other old or new business for the board?
You're not done with me yet.
Oh, I'm not done with you? What am I?
No.
Sorry, I don't know how
Double
to use two
feature.
screens.
This,
We should always be
this
so
should
lucky,
be-
Laura.
This should be very brief. I need once again to share my slides in Teams. So what came out of the process issues we had this year with Blue Cross's proposal was it was suggested that we edit the process for non-standard QHP proposal review, and General Counsel Barber suggested we do it now while we're thinking about it. So we created these proposed edits to the process. The red line is here. It's intended to clarify the process by requiring written proposals, setting a clear deadline with a date, providing the contact info for how the proposal should be submitted, and then updating the timeline for notice to the carriers about presenting, because the 30 days has never worked. This was the process we suggested. Dr. Merman?
I'm just seeing your first slide,
Oh.
and I think you've moved to
Oh,
a
I'm
second
sorry.
slide.
I'm moving the wrong things. Apologies. Here you go. There you go. Give you a minute to look at it. I'm sorry.
Thanks.
Right.
I think you can continue.
If you're ready, I can go to the next slide. Just talks about the process. We circulated the proposed edits last week by email to the HCA, to MVP, who said the changes were acceptable, and to Blue Cross. And it was, that was where we get the helpful suggestion to put specific email address and contact info into the submission requirement. So that's included in the presentation today. So I have some draft motion language if these tweaks to that process are acceptable to the board members.
I'll make the motion and then we can discuss. I move to approve the proposed changes to the process for non-standard QHP proposal review as reflected on slide 2 and discussed today.
Second.
Any board member discussion? Any HCA or public comment?
Just that we fully support the process improvement. Thank you.
Thank you. All in favor of the motion, say aye.
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 Aye. Motion's approved. Ms. Belleville, anything else I forgot today?
Not for me. Thank you.
All right, I'll check in with you at the end of the day. See what else I forgot. Any other new or old business for the board? Okay, then I move to adjourn.
Second.
All in favor, say aye.
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 Aye. We're adjourned. Have a good afternoon.